Good morning. I want to welcome everyone for our third meeting of the Payment Models Work Group. Just a few housekeeping issues, and then we'll get started into the agenda. When you speak, please pull the microphone close to you so that you'll be recorded, and others who are joining by WebEx will be able to hear you. We've added, in the revised work plan, we've added a firm meeting date. It's not yet printed out, but the May meeting will be on May 19 from 2 to 5, and you'll get that updated pretty soon, but just to be able to mark your calendar on the second page. Also, there's an MHCC commission meeting in here at noon, so we're going to be making sure that we end our meeting promptly at 11 o'clock today in order to allow them to get set up for their meeting at noon. In terms of our agenda today, we're going to do a brief run-through on some initial uncompensated care analysis and directionally where we're headed with uncompensated care for this year. Then we're going to focus on Care First white paper on the annual update process. We have Jack Cook, who will be joining us by phone and webinar. Then we'll have some time to go through a discussion of the balanced update, including some refinement of the principles that we started last week to help guide us through discussion. So that's the plan of attack for this morning. We sent out a white paper and a PowerPoint on and we're moving on to the uncompensated care discussion. And we sent out a white paper relative to some work that we did with the Medicaid enrollment in the primary care in the primary access program, which we'll briefly touch on here. But I thought it would be helpful just to give some sense of where we're headed with uncompensated care. While we don't have a great deal of time to get into discussion of it today, at least we can get it on the table and begin thinking about it. Every year we update the uncompensated care adjustment, and the uncompensated care is a pool approach where all hospitals receive the same amount of revenue and rates for uncompensated care, and then there is either funding into a pool or withdrawal from a pool based on the amount of uncompensated care that is calculated for each hospital in the state. So if the allowed uncompensated care for a hospital is higher than the amount in rates it receives money from the pool, if it is lower, then it pays into the pool. So that's just kind of a high-level overview of how uncompensated care works. And then all payers share in the cost of uncompensated care. Each year we review the amount that is included in rates for uncompensated care based primarily on what occurred in the last fiscal year. And for fiscal year 13, there was an increase in uncompensated care reported by hospitals on their annual reports. And that increase of fiscal year 13 over fiscal year 12 was approximately 0.5%. So in the usual application of the policy, we would review that, and it would be funded as part of the annual rate adjustment through the payer differential calculation in terms of how we apply the markup to the rates of the hospitals. So that would normally be something that we would be funding. And of course, with and it's part of the overall revenue increase that we're looking at as part of this 3.58% per capita growth. It's allowed, so obviously it's important for us to nail down what is going to happen with uncompensated care, because it does affect the amount of money that is available under the 3.58% maximum increase. We have, because of the Affordable Care Act, we have the situation where we're looking forward and we're expecting, starting January 1, so already underway, that there will be a reduction. I think the latest head count of enrollees under the Affordable Care Act are some 220,000, 240,000 new enrollees. And that includes about 145,000 Medicaid enrollees. About 96,000 of those Medicaid enrollees were part of a program where they were already enrolled, and but only part of their costs were covered. For the hospital, only their emergency room costs were covered. So their inpatient care and their other care was not covered in the hospital. So on January 1, they were automatically converted into full benefit Medicaid enrollees. We'll talk a little bit more, and the more extensive paper that you received via email that you may or may not have added to your reading list yet goes through the process that we use to accumulate charges for those enrollees by taking their Medicaid enrollment number and attaching it using CRIS back to their claims on an historic basis. And when we do that, for those 96,000 enrollees, it accounts for about 1% of charges. So effectively, we would expect to see a 1% reduction in uncompensated care, which is about 15% of the total amount of uncompensated care that is in rates. And for some hospitals, we'll look at a list a little bit later, but for some hospitals, it accounts for close to 1/3 of their uncompensated care, these PAC enrollees. So it's a fairly extensive enrollment expansion, primarily to adults without children, and also to a very high user group. We'll get back into that, but effectively, we're focused on using that information to be able to provide a reduction in the uncompensated care levels funded in rates due to this expansion that happened on January 1. Then the third thing that is underway is really looking at the variables that are used in the uncompensated care formula, which we'll review in a minute. But the variables that have been used for quite some time. Some of them go back to more than 20 years ago in terms of when they were initially constructed. But with the change in the uninsured that is caused by the Affordable Care Act, some of these variables may not work as well as they used to. And in fact, one area that we've begun to notice is the impact of undocumented immigrant populations on the calculation, and the lack of recognition of those populations in terms of funding of hospitals, bad debts where those populations are concentrated. So that is a particular problem that we're trying to explore. And then as we have more and more, historically, we'll see in a minute that we've used Medicaid in the formula to predict where the presence of Medicaid to predict where we might expect to see high bad debts. If there's high Medicaid, there are probably high uninsured populations in the same hospital service areas. Well, as the Medicaid coverage has continued to increase and more populations are covered by Medicaid, that may not be as good of a predictor of bad debts as it once was. So that's something else that we're trying to look at. Next slide. So that was a long time on slide 1, but it will really move us forward quickly through a lot of the other slides, since we really want to spend most of the time talking about the update process with Jack. So I think I already covered the next slide on uncompensated care in Maryland and what that represents. On slide 4, I briefly indicated that we use a regression methodology to predict the actual uncompensated care costs for a given year for each hospital, and this estimates what we would expect that hospital to incur as uncompensated care. And the reason that we do this is to make sure that hospitals are applying similar collection efforts and collection policies as other hospitals, so that we're not providing an uncompensated care adjustment just because someone doesn't do a good job of collecting their receivables. On slide 5, even though we have this regression, we use it only in a 50-50 manner, and that is that we provide a blend of this regression predicted value for the hospital along with its actual uncompensated care levels based on a 3-year moving average. And we've used historically the 3-year moving average to create some stability in the hospital levels and not be plagued by the ups and downs that can occur in hospital provision. The hospital's preliminary amounts and rates are adjusted, and then the pool funding or withdrawal is then recalibrated each year based on this formula. So I know that's a lot, and if you actually look at the details, it'll take you a little while to figure the ins and outs, but at a very high level, some pay in, some withdraw based on this regression formula and blending of actual results for each hospital and their predicted rate compared to the average rate in the state. Currently, and I'm moving on to the next slide. Currently, the variables used in the regression calculation. The first variable is the proportion of the hospital's total charges from inpatient non-Medicare admissions through the emergency room. So, and actually, and that really was to focus on emergency care as being a high predictor of uncompensated care. In our preliminary work so far, that variable is no longer working as being statistically significant. So that one may bite the dust this year. The second and the next set of variables relate to the hospital's charges from self-pay, charity, and Medicaid. And we have one variable based on inpatient and another based on outpatient. And this is where we're unclear on whether having Medicaid in the formula of looking at as a predictor of uncompensated care, whether that is still going to be a good way to look at the predicting uncompensated care. So we're looking at alternative formulas to try to incorporate to predict the uncompensated care. Then I think we talked about the inpatient emergency room charges. Now we also have the outpatient emergency room charges, and as I said, those variables with emergency room charges are not holding up in the equation. So those are areas where we're looking for new variables, and actually one of the things that we'll ask Mike Robbins and the hospitals to weigh in on are, as they see their bad debts developing, are there new factors that they think we should put into the formulation this year to try out as variables, since we are going to undergo some considerable change over the next 2 to 3 years as we continue to see the impact of the new enrollment under the Affordable Care Act. Also, we've been looking for variables relative to the undocumented population, and those have been somewhat difficult to nail down. Although we have gotten some information from Medicaid, and also we're exploring some census type of data. The next slide is a trend slide showing the trend in uncompensated care over the last several years, going from 2009 to 2013. So the percentage dropped down into the 6s, and in 2013 it moved back upwards just slightly north of 7%. There are several thoughts about why it increased. One of the thoughts relates to high deductible health plans, and also perhaps the movement of more services to the outpatient side of the business, where the bad debts tend to be a little, and bad debts and deductibles tend to be a little bit higher on the outpatient side of the business. So that appears to be possibly driving some of the increase, but others may have some other thoughts about drivers.
Just a quick question on this chart. Just want to clarify that this is actually the amount of uncompensated care, not necessarily what was built into rates in each year. This is the actual, if you will, uncompensated care that the hospital would have reported on their financial statements.
Yes, so it is the actual uncompensated care from the financials, but at least for 11 and 12, and I can't speak to the other years, but I personally looked at 11 and 12, and these are the actual amounts that were provided in 12 and 13, because it runs 1 year behind. So in 12, the 11 amount was provided, and in 13, the 12 amount was actually provided in rates. In the it didn't change between 11 and 12. It was within 1/100th of a percent.
Yeah, what I was just getting at, and I don't want to belabor
Right,
this because
okay.
it's a technical issue, was that this does not reflect the prospective adjustment in rates we were making for the so-called averted uncompensated care back in 2010, 11, and 12. This is exactly what the uncompensated care was, if you will, on the financial statements in each of those years. Okay. Thank you.
I don't think we need to comment. So what? How did that compare to what was set aside in the uncompensated care pool?
I don't know, and that's why I was asking the question. I just wanted to see whether how that trend, the two trends moved with each other. I think that would just be informative in terms of understanding the current policy.
There were some differences in uncompensated care between what was put in the rates and what actually occurred, as there always is every year. The problem, what we always do, though, is there was some reconciliation where hospitals received money when they were, when too much was removed from rates, and we expected uncompensated care to drop more than it actually did. Some of that was restored to the hospitals, and we did eventually move to whatever the actual amount was for the prior year. So as the actual amount came in, we used that in the following year. So this accurately reflects what hospitals did incur.
Again, I don't want to belabor it, but the drop from 2009 to 2010 looked very large to me, and I thought it might have been because, in addition to what might actually have been occurring, that we also reduced rates prospectively as is being proposed for the PAC population now for what we thought would be an expansion, a reduction in uncompensated care related to the 2009 Medicaid expansion. And so it's not what I was suggesting is that that drop from 2009 to 10 was not necessarily a drop in uncompensated care as much as an anticipated drop that we built into the rate structure, and that's what I was trying to tease out. So again, I don't want to belabor that now because we have a lot of other important things, but if we can show the two numbers.
We can just ask, Andy, this is actual, is it not, or is it funded?
Okay, well, that's what I was asking. Thank you.
And Mike is right. What was actually provided to the hospitals during the last Medicaid expansion was an amount that took into consideration the actual that occurred plus the expected change for the upcoming year, similar to what we're doing right now. That's what we're trying to do.
But hopefully we have better data to do it with this time, since we actually can go back and link individual enrollees to prior hospital utilization.
Can I ask a quick clarifying question for the non-hospital people? I'm struggling with this discussion in terms of how much the rates are prospective and fixed and how much there's a retrospective settlement for changes that occur that aren't anticipated. And so with just this uncompensated care piece, is if the actual that is experienced next year is different than what you predict, is there some retrospective settlement or not, or is it what's prospectively set is prospectively set and they get it regardless?
Normally the amount that is set prospectively, that is the amount that is provided, and there is no retrospective adjustment. What Mike is talking about was when Medicaid went through their last expansion, there was a decision made here that we would try to anticipate how much the bad debts would be reduced, and we made a reduction to that. We also, though, said that we would, at the end of that, we would look at how much bad debts were reduced relative to what we thought was going to happen, and then we would try to do some settle-up. That was promised by the Secretary of Health at the time when the Medicaid expansion took place.
Okay, so that was a one-time settle-up.
It actually occurred for probably 3 years. Yes, as that expansion continued to ramp up, okay, we continued to take some additional money out of hospital rates.
Okay, but traditionally it's prospectively set. You guess And then if uncompensated care is less, the hospitals keep it. If it's more, the hospitals eat it.
Yes, that is normally the way it happens.
Okay, so what we're trying to do is figure out the right setting for a prospective guess, and depending on whether we guess one way, right or wrong, one way or the other, either the state overpays or the hospitals eat that.
Well, I think we're trying to do two things here. One is...
Did I get that right?
Right, but there's a second. One thing we're trying to guess exactly how much do we expect bad debts to change over the next year because of the Affordable Care Act.
Right.
But the second piece of that is then how do we distribute that amongst hospitals? Before we use different variables to estimate how much each hospital should receive, and now we're going to look at, we think things are changing, so we need to re-examine the variables that we use when trying to figure what each hospital should receive in the way of an approved bad debt amount.
And how that intersects with the pooling, which seems to tamp down on that there's this pooling you pay in and you take out, that seems to moderate that hospital-specific stuff somewhat. But so I'm a little confused on where the regression fits into that.
Well, the amount that goes into rates, what's approved, okay, is one number. What goes into rates is the average of all those approvals. And so the average goes into every hospital's rates. The hospitals whose actual approved is below that amount, they pay into this fund. Okay. The actual whose amount is above, they receive money from the fund. And so
but it's
it is important.
Prospectively set.
It's prospectively set, and the payments are made.
The fund isn't based on actual experience. It's based on set rates.
Yes,
right. That's where I was confused. Thank you.
And that's to provide hospitals an incentive to collect. I mean, we always tried to provide an incentive.
I have a question. Is there a uniform understanding of the difference between or charity care and uncompensated care?
You want to answer
No.
it?
So I think there's been an attempt to do a better job at identifying charity care, but I don't think that we don't believe that it's being done uniformly across the state, and it's not always a simple thing to approach. So I don't think it's being done uniformly based on the data that we see.
I was glad to see this big drop in uncompensated care due to the Medicaid expansion. It's crazy. Is there any way to know? Oh, I'm sorry. There's any Marco. I'm glad to see the big drop in uncompensated care. I'm glad to see the big drop in uncompensated care due to the Medicaid expansion of 2008. Is there any way that was reflected in insurance premiums for people? Did that reduce in any way the rates and insurance premiums?
Well, to the extent that folks pay directly based on actual hospital charges, then those who are in plans that pay based on actual hospital charges, which is most of the large employers in the state, then that would be directly reflected in the amount that they pay as a reduction. And to the extent that the insurers filed for lower rate increases, and I can't answer that question, but if insurers filed for lower rate increases, then it would be reflected in lower rate increases that were filed for commercial insurers, and it would definitely be reflected in lower payments by Medicare and Medicaid. So, so we can answer that on a definite basis for all but the fully insured populations where of commercial insurers, where it would be based on their rate filings or the rates they charge their enrollees.
And just to comment on that, 65% of basic business is non-risk. So the employer would see that in their claims experience, and then for the remainder, it would be funneled into the trending that insurers would do in calculating the premiums. So it would be factored ultimately into the premiums going forward.
Clarity, because Mike, I thought you said, and that this is learning process, that the estimated drop of uncompensated care with the Medicaid expansion was not realized. Maybe it was. So again, going back to trying to understand these numbers, but that was again something that I just want clarification on.
And again, I was just raising the question of the rate that we saw there was a function of two things. One, which was the actual reduction in uncompensated care, plus this prospective adjustment that we made for the assumed further reduction in uncompensated care that would occur due to the expansion in Medicaid coverage going through 2009 through 2012. Andy has clarified that this does not include that second adjustment. This is just the actual reduction in uncompensated care that was occurring in those first years and then flipping back up in 2013.
So in terms of on page 9, or slide 9, in terms of looking at the potential expansion moving forward, what we have done, and we submitted a fairly extensive paper, which we're not going to review here today in detail. We took the PAC enrollees. We obtained enrollment data from Medicaid for the 96,000 PAC enrollees. We linked it with the CRISP ID, and we went back and looked to the last year to see what the charges were for those individuals in hospitals in Maryland. And we excluded emergency room charges since they would have been picked up by Medicaid. So we accumulated the inpatient charges and we accumulated the outpatient charges other than the emergency room charges. And when we do that, it represents, it adds up to about $150 million. I don't have the exact figures in front of me, but it was roughly $150 million, with the bulk of those being inpatient charges. This particular population is a high user group with a very high hospital use rate, higher than the average hospital use rate in the state, and a population that uses the hospital fairly regularly. So we accumulated this particular group because we were certain that when we looked into the past that we would be most likely looking at charges that had been uncompensated, and that we could be fairly accurate in our assumption that these would be averted uncompensated charges going into the future. We can also do this sort of analysis with the remainder of the Medicaid enrollees, but we'll find a different picture when we start getting into other enrollees, because the other enrollees may have had other insurance and other forms of payment to the hospital in the past, whereas this particular group of enrollees has very little noise in the data in terms of any kind of indication that they paid. The highest indicator of possible payment is some of these enrollees are marked as Medicaid, even though they're PAC. And they are Medicaid, they're just not full Medicaid. But for the most part, they're fairly clean in terms of being marked as not paid by a commercial insurer, et cetera, and so forth. So, we intend to move this information forward in terms of looking at its impact on the uncompensated care estimates. And as I indicated, it does account for about 15% of the current uncompensated care level, and for some hospitals, it's almost a third of their historic uncompensated care. we do have a handout that shows the amount by hospital. There's a sheet that looks like this that was in the handout here. It was in the PowerPoint, but it required a childhood eyesight instead of. I know I couldn't read it, so we do have a handout here that lets you take a look at the PAC inpatient charges and PAC outpatient charges by hospital facility, and then you can compare that to the gross revenue of each hospital, the uncompensated care level of each hospital, and you can begin to see the significance of those numbers to particular hospitals.
But Donna, these will be pulled out because they'll be insured going forward. The PAC clients will be fully insured under Medicaid for the hospital.
Yes, they're now fully insured under these individuals are now fully insured under Medicaid, so their hospital charges would no longer be would no longer become bad debts.
Okay. What I'm struggling with, and it was brought up a little bit before, is the difference between defining uncompensated and true charity care. And the true charity care, from my understanding, is the true totally uninsured. Such as the people who don't have insurance were not able to get it through the Affordable Care Act, through the exchanges such as the undocumented, versus the people that may have insurance but have high deductibles and high co-payments, for which there is an expectation that hospitals would try to bill and collect on those deductibles and co-payments. The Medicaid population, to my understanding, doesn't have deductibles and co-payments. The PAC patients don't have deductibles and co-payments, so the focus may need to go on the people that are insured but still have a large cash balance to pay, and that may become a significant portion of the uncompensated care as the true charity care, the undocumented, that will be true charity care.
Yes, I would agree with you, and what I would say is that these PAC individuals represent people who would really be true charity care prior to being on Medicaid, because they're on Medicaid because they don't have other insurance or resources. And up until January 1, they weren't paying their hospital bills. Medicaid paid only a small portion, representing the emergency room coverage for these individuals. So they were true charity care. And I think your characterization going forward that there will still be charity care. Some of it will be coming from individuals who are perhaps undocumented immigrants. Some of it will be coming from high deductibles for people who can't really afford to pay can't pay $2,000 or $5,000. They can't afford it. And then bad debts, which is a recurring cost that hospitals need to attempt to collect the money, but is a recurring cost that we recognize in rates. Thank you.
Just a little bit also of a clarification on the charity care. You still will have folks who, while they are eligible to get coverage through the exchange or through Medicaid, who do not opt to get that coverage, who, because of their income levels, would be eligible under most hospitals' charity care policies for either full or partial charity care. So I would say that will still continue even as we expand coverage through the exchange. So that is something that will still occur. It will not all move to just bad debts, if you will, being the overwhelming share of the total uncompensated care.
Mike?
Donna, maybe I can follow up a little bit on Ann's comment. I think it will absolutely make sense for us on a go-forward basis to study the high deductible plans and the impact more of the shift from inpatient to outpatient. Not only does it have economic considerations, but from a patient satisfaction experience, it's an incredibly confusing and frustrating process for them. And I think a part of our responsibility collectively are the communities we serve. And I can tell you the effort that goes into trying to collect dollars relating to a high deductible plan are significant. So also the administrative expense associated with trying to collect those dollars are much more than we anticipated. So again, there's an economic consideration of these that we need to understand, but I would like to say in the back of our minds, we always should be considering the patients in our communities, and these are frustrating programs for people to be in. They just don't think it's going to happen to them, and when it does, it puts them in economic distress. So, you know, I think we should keep that on our agenda and study it carefully as we go forward.
But I'm assuming, too, that hospitals make every attempt when the hospitals gets a patient to see if they're eligible for anything particular and to enroll them into Medicaid.
Absolutely.
And also, fortunately, with the Affordable Care Act, with certain you know, income levels, not only is there premium support, but there's also support for deductibles and copay, and the out-of-pocket expenses are capped. So I'm sure hospitals would make every effort to explore that when they had a patient in hand and get them enrolled and get the benefits started as soon as possible.
And that goes back to the administrative, but some of these are also private insurers. Companies are making decisions that, you know, these high deductible plans are clearly the way they want to go, and in that particular case, the employees have less of an option.
I think there's also a realization now that there are a significant number of folks who are not signing up for the exchanges that are not Medicaid eligibles, but folks who just are currently uninsured. And I think the expectation going in with the Affordable Care Act is that there would be a larger number of those uninsured signing up. We're not actually seeing that happen to the extent that was projected. So I think there could still be, and we should factor in, the number of individuals who are not Medicaid but are not insured. So we're not going to see, so far the data are showing we're not seeing the number of folks signing up through the exchanges that we had originally anticipated. So that could still be an issue for hospitals on the uncompensated care.
Right. So I think what we're doing at this point is taking a little bit more of a wait and see for those who have already signed up. We will need to continue to pay attention to it to try to get information on those individuals. I understand that only about half of those who did sign up have actually paid their premium. So even if they signed up, they might not actually be getting insurance because they haven't come up with the money to pay for the premium on the new policy.
Exactly, and even those that qualify for, or would qualify for subsidies, there's a large portion of them that are not even aware of what what they're eligible for. So, and Vinny may have additional insights on this, but I know that there's a significant chunk of Marylanders who are not signing up, even though they could qualify for subsidies.
So the focus of what we're trying to do here is to take the area where we think the averted bad debt is, I'll say, incontrovertible, but one never wants to go quite that far. But where it's solid, and so we haven't included all of the Medicaid enrollees, and we haven't included the other exchange enrollees, but we will want to quickly, when bad debts go down, we'll want to quickly reflect that, recognizing that there may be an upward tick going from the high deductible plans, and so we don't want to get ahead of ourselves on one hand when things are pushing them up on the other hand with the high deductible plans. So that's the strategy that we have, is to take this particular population but not every other enrollee and to take it into account.
Smart, conservative way to do it.
So do I understand that the rest of the formula will stay in place, and you're certain of the PAC number, so you'll take that out of the mix, and then the rest of it stays in place, even though we know there's all this other stuff going on? Is that because you have to guess next year, and there's so many moving parts and no data to figure it out?
So we're not making a presumptive assumption about the other 100,000 enrollees that they'll reduce bad debts. We're focusing on this group because we know how much their hospital care was in the past. We're not saying, oh, we have 100,000 other enrollees and therefore bad debts will go down for the other 100,000 enrollees. We do need to change the formula, though, because the hospital-specific formula isn't working as well as it needs to for the undocumented folks, and obviously this particular adjustment will have a hospital-specific impact because some hospitals have a much heavier population of individuals who are PAC enrollees.
And that really was where my question was going to be. I was curious, again, for maybe outside our meeting today, to see what these similar numbers for PAC population would have been for 2012. Curious whether how much of that 0.5% growth in uncompensated care was attributable to any growth from 2012 to 2013 for this PAC population. I think that's part of understanding how much of an adjustment into that 0.5% that's going in the other direction we need to be making for that population. And also be curious to see what the use rates were for the remaining uninsured in the same fiscal year, to see whether how the PAC population use rates compare to the rest of the uninsured, if they're similar, if they're dissimilar, because what we're making here is the assumption that when they get coverage, essentially the use rates will be the same, as I'm understanding that, by taking that out. And so to a certain extent, I think I'd just like to understand a little bit more about how unique this population may be and what we can predict about what their use rate of hospital services will be now that they've gotten coverage, full coverage through Medicaid, whether that will improve, whether they'll stop using hospital services, use it in greater numbers. I think that's part of the challenge of understanding what kind of adjustment to make.
So you said that you wanted to take the conversation offline on that. Is that what you were suggesting? Right. Because we've got enough.
Because I know we have so many other things on our work plan. If it's just as we finalize what that adjustment, if any, is going to be for the PAC population, I think there's some additional information that we're going to need to understand whether it's this full 1% or not that should be adjusted. It could be more, it could be less, depending on what we can further understand about those patients.
So do you suggest a smaller work group, or should we have a webinar, or what are you suggesting, Mike?
I would suggest a separate work group if that will help move this thing along more quickly. That's fine. Okay.
We'll at the end today, we'll take some volunteers for that, or some designations. So I think we need to come back with some additional calculations, work with the smaller work group, and come back with more specific calculations for review in the process. But just presenting that as with the information that we have in hand now, that we see about a 0.5% increase offset by about a 1% decrease from the PAC population. And not to further take up time from the discussion of the annual update factor, I want to turn to Care First and to Jack Cook to go through a PowerPoint presentation that Jack has prepared to go along with the white paper that Care First submitted.
Okay. Let me begin by mentioning that the thrust of this paper is to propose a process for establishing the annual updates. It's not to suggest either that the statistics that are used in the examples don't need to be updated, or that the estimates used in the examples are correct, but rather the emphasis was to use those statistics and estimates to illustrate the process that is the essence of the proposal. If we go to page 2, I've enumerated there the 2 key waiver tests of the demonstration. I think everyone knows what those tests are. And a key purpose of this annual allowance calculation is to ensure that both waiver tests are met throughout the term of the demonstration. Go to the next slide. There is, of course, within the demonstration a provision which allows for an adjustment to the Medicare and Medicaid differentials in the event that the first of these waiver tests, the all-payer ceiling, is met, but that the second of the tests, the Medicare savings target, is not met. And one of the purposes of this approach is to avoid the use of this particular provision, in part because we believe that it would be very detrimental to both the hospitals and the citizens of Maryland if it were employed. So go to page 4, please. The Medicare savings targets are formulated in a manner within the demonstration which I think is a little bit obscure. They require that the cumulative Medicare savings relative to the national average rate of increase in hospital claims for Part A and Part B services per fee-for-service beneficiary total $330 million over the demonstration. If one is to convert this into an annual savings requirement, in other words, an amount that if the hospitals were to save this particular amount each year, it would equal the $330 million, that conversion is about 0.44%. So effectively, the Medicare savings targets are requiring us to operate at 44/100% below the national rate of increase in hospital claims per fee-for-service beneficiary. In our view, a failure to meet the Medicare savings targets would disqualify the demonstration as a population health initiative, largely because the standard is not unreasonable. At least it's not unreasonable within the context of the most recent experience that we've had. So we go to page 5, please. The difficulty that would be raised by adjusting the Medicare differentials would be, first of all, that we would have failed one of the key tests of the demonstration. And as such, a failed demonstration would provide no clear basis for the renewal application, which would be due at the end of the third year. In fact, if we made use of this differential early on, it's certain that the increased differential would be in effect in the third year, and in my view, that would undermine CMS's confidence that the demonstration should be continued past the fifth year, and the implications of that for the hospitals and for the state is a reduction in Medicare payments of approximately $1.5 billion. So we go to slide 6. Now, the thrust of this approach is to focus on a single statistic, which has as its purpose the establishing the relationship between the two Medicare waiver tests, the all-payer ceiling and the Medicare savings targets. So while this is a little pedantic, I want to go through this definition. The all-payer growth rate is the statistic that's used in the all-payer ceiling. It's the percentage increase in Maryland hospital charges per Maryland resident in the particular year. The Medicare growth rate is the percentage increase in total Medicare hospital claims per Maryland fee-for-service beneficiary in the particular year. And the statistic of importance is the difference between those two. And I've called that the difference statistic because I want to be able to refer to it over and over again. The thrust of this proposal is that we need to calculate the difference statistic. We need to evaluate the factors that give rise to its current level. We need to evaluate the variation that may occur in this statistic over time as a result of random factors that we don't understand. Then we need to be able to project the statistic. And as a part of the overall rate-making process, we need to make use of initiatives, many of which the staff have already introduced, which will maintain the statistic. Because by maintaining the level of the difference statistic, we essentially establish an equality or a near equality between the requirements of the two tests. So let us go for a moment to the first step here and look first at what the all-payer growth rates have been. This is page, okay. This schedule calculates the annual percent increase in the all-payer statistic and shows, somewhat surprisingly, that over the last 5 years, this growth rate has averaged 3.63%, with 2013 being somewhat of an outlier in that year the growth rate was only 1.2%. Now, that's the first component of the difference statistic. The next page shows the calculation, the estimation, I should say, of the Medicare hospital charge growth. Now, this is an estimate for two reasons. First of all, because the statistic that is used to measure the Medicare savings target is the total hospital claims, both in Maryland and outside of Maryland, per fee-for-service beneficiary in Maryland. These claims only include the Maryland component. And the second feature of the estimation is that these measures of the number of Medicare fee-for-service beneficiaries are taken as an estimate, and that estimate is the number of people who are over the age of 65. It is not true that the number of people over 65 will be identical to the number of Medicare fee-for-service beneficiaries. However, it is true that the rate of increase in the people over the age 65 will be very close to the rate of increase in the number of fee-for-service Medicare beneficiaries. And it's only that rough equality that's necessary to make the estimate reasonable. Now, over the 5 years, you'll see that the experience in Maryland has been remarkably favorable. That is to say, the annual increase, according to these estimates, is only 0.69%. And again, 2013 is a bit of an outlier with a negative 1.1% increase in that year. Okay, so we are now prepared for the next exciting step, which is to calculate the difference statistic for the last 5 years, and that's done on the next schedule. The key point here is that in column 3, the difference statistic is calculated for each of the 5 years, 2009 through 2013, and the average taken at the bottom of the page being 2.94. This is a remarkable statistic at this point because what it's saying is that the rate of growth in hospital claims per resident has been 2.94% greater on an annual basis than the rate of increase or the estimated increase in hospital claims per fee-for-service Medicare beneficiary in Maryland. And if that differential were to be maintained, the requirement of meeting the two tests would be fairly easy. So let us go to page 10 because we want to understand why the statistic was at the level that it was over the last 5 years. We want to understand how the statistic will vary from one year to another, and we want to understand how the projection of the statistic would be central to the calculation of the annual allowances. However, before I leave this schedule, I just want to note that in the fourth column on the right, I have calculated what I've called the absolute variance. This is an unconventional measure of variance, the statistic. It is simply the absolute value of the difference between the statistic in any particular year and the average. And overall, this variance is 0.79%. So one interpretation that could be given to that statistic is that this is what you might expect to be the amount that the statistic would vary from one year to another for reasons that we don't understand. And therefore, it could be one consideration in establishing a conservative estimate of what this differential statistic actually is. Okay, so I'm sorry, if we go on to 10, please. Now, in order for the difference statistic to reconcile the two waiver test requirements, which is what the purpose of the difference statistic is, we need to have several key requirements met. The first is that we need to have the maintenance of the difference statistic based on the continuation of the factors that are producing its current level, because it's that maintenance that is necessary in order to make the projection. Secondly, we need to have initiatives that are designed to maintain the level of the difference statistic. And as I suggested, the staff has already developed some programs that would work to that end, and their suggestion embodied in the policy of Go for Zero would be a very welcome policy for those purposes. And then the third requirement for the use of the difference statistic in the methodology is the accuracy of the CMS actuarial projections. And those are introduced in this discussion with the understanding that we will need to update them as they become available, and we need to take a conservative view of the accuracy of those projections, because they will be crucial in our establishing an annual allowance that will meet the Medicare savings target requirements. So next page, please. Okay, so in projecting the difference statistic, I would suggest that it's very important that we begin with a conservative projection. And the reasons for that are, first of all, that our estimate of Medicare claim scores per fee-for-service beneficiary, which you'll recall is, I'm sorry, grandson, which was projected on Schedule 2, may indeed be understated. Secondly, the experience of the hospitals in 2012 relative to Medicare was far more favorable than we can expect in the future, because in that year we had highly depressed inpatient rates, relatively high levels of increases in outpatient charges, and that mix of rate increases will cause Medicare claims for fee-for-service beneficiary to rise far less than if the rate increases were across the board uniform. Third, the factors that, other than this differential rate increase, the other factors that have produced Medicare's relatively low increase in Maryland hospital claims may not remain in full effect, and we will examine those in a moment. And finally, as a statistic, the difference statistic is variable. It's a random variable, and therefore there's some inherent variation in it that we won't understand, that we can't understand because of its character as a random variable. So let's go to the next page. The first consideration I want to propose is that we look at the inherent variation in the statistic. Now, you'll recall that on the Schedule 4, I had done this unconventional calculation of variation, which suggested it was 0.79% was the expected amount that it would vary from one year to the next. The second way of measuring variance is the standard deviation. That's the usual conventional statistical method. And so we have here two measures of variation of the statistic. And if we consider those measures in the context of the experienced average of 2.94%, my view would be that it would be reasonable to establish as a conservative projection of the difference statistic a 2% projection, because that 2% projection would basically account for the actual experience less, more or less, the average of these different measures of variance. So we go to the next page then. Okay, now the next key thing about the difference statistic is we want to understand what are the factors that have given rise to it in the past. In other words, we've seen that it was remarkably high over the 5-year period, 2.94%. And one of the reasons for its relatively high level is the fact that Medicare services are distributed differently than the services of all payers. So in particular, Medicare, as you know, has a disproportionate level of inpatient care, which in Maryland is 77.6%. And inpatient charges per resident have increased at a much slower rate than outpatient charges per resident. So the annual effect of this odd distribution of Medicare services between inpatient and outpatient is actually to cause the difference statistic to vary by about 1%. And that calculation is on the next page, 14. I'll just mention this, the details of this calculation quickly. On the first line, we break down the Maryland hospital charges between inpatient and outpatient for residents over the age of 65. We then calculate the percent of inpatient to total and outpatient to total. And on the third line, we record what the annual increase per resident charges has been over the 5-year period, 2008 to 2013, for both inpatient and outpatient services. We then combine those together, and we see that if Medicare had experienced the average increase in charges per resident for inpatient and outpatient services, its growth rate would have been 2.67. Whereas for the all payers, it was 3.64. So 1% or 0.97% of the difference statistic of the 2.94 average is explained by this service mix, this odd service mix that characterizes Medicare service delivery. Okay, next page, please. Now, the second factor, which is also very important in explaining the difference statistic, is the disproportionate reduction in discharges for Medicare beneficiaries versus all payers over this 5-year period. We calculate this effect on the assumption that the discharges had the same average case mix as the folks who remained in the hospital, and that hypothesis is obviously incorrect, so we'll have to adjust for that at the end. But let me turn to page 16 where we do this calculation. The first line of page 16 indicates the total Medicare discharges in 2008 and 2013, and as you can see, they've dropped substantially. They've had an annual reduction of about 1.4% per year. On the other hand, the residents who are age 65 plus, our estimated statistic for the number of Medicare fee-for-service beneficiaries rose from 659.6 thousand to 784. So our discharges per 1,000 residents have dropped substantially for Medicare at a rate of 4.76% per year over the 5-year period. When we do the same calculation for all payer discharges, we find that the total number of discharges has dropped, this is on line 4, by 2.3% per year. And when we take into account population growth, we see that that reduction is 2.91% per resident. So Medicare's reduction in discharges has exceeded the all-payer reduction by 1.85% per year. 77% of Medicare services are inpatient, so we multiply those two together, and we conclude that if this reduction in Medicare discharges had had the same case mix as the folks who were left over, it would account for 1.44% of the 2.94% of the different statistics. Now, of course, we need to adjust that 1.44% down because the discharges that were eliminated generally had a lower case mix, probably about 0.8 or so. And so the amount that this differential reduction in discharges accounted for relative to the overall different statistic is probably a little bit more than 1%. So in other words, those two factors, the distribution of Medicare claims over inpatient and outpatient versus all-payer, and the differential reduction in Medicare discharges versus all-payer account for 2% approximately of the different statistic. And if the programs that the HSCRC maintains can sustain that kind of differential reduction in resource use for Medicare on the inpatient side or through some substitute in other services, then given that it's likely that the Medicare distribution of services between inpatient and outpatient will remain as it is now relative to the private sector, and given further that it's likely that inpatient charges per resident will be rising at a substantially lower rate than outpatient charges per resident, it's not implausible that the different statistic could be sustained at 2%. So if we go on to 17.
Yeah.
Now,
we have a question.
I think we're using a term of art and a clarification that is some people's head scratching over here. Declining Medicare discharges means probably fewer Medicare admissions to the inpatient side as opposed to Medicare patients being admitted but dying in the hospital and not getting discharged. Correct?
Yes,
No,
right.
They're discharged even if they pass in the hospital.
So it's fewer. The thing is fewer patients being admitted.
Correct.
Correct.
Okay. So there's been fewer medical admissions in particular.
Right. Okay. That was just, we were just having a discussion as to what that meant.
Yes. So yes.
All right.
We have another question.
Another question. This is Stu.
Okay.
I'm a little confused because on the slide 14, where you show the Medicare growth in charges per resident, wouldn't the change in the mix of services be embedded in that? Because you're talking about charges per resident, which is charges per discharge times discharge per resident, right? So I'm wondering whether these actually are two separate factors or whether one is embedded in the other.
I'm not sure I understand the question.
Okay.
What the idea is that the charges per resident are going to account for both the modification in discharge levels and the charges per discharge. And the key point is that in Medicare, I'm sorry, let me go back a second. Let's strike that. The key point is that because of the mix of Medicare services and the fact that they're disproportionately concentrated in areas where the rate of inflation is low, we're calculated on a per resident basis, the relative rate of inflation in Medicare charges per fee-for-service beneficiary will be lower than the corresponding amount for all payers. I'm sorry, but I don't think I understood your question.
Well, just to clarify, so think what you're saying, and I think Jack is saying this too, but I'm not sure, so I just want to ask for clarification. You're saying that the reduction in discharges is part of the difference in the charge per resident, and I think I think Jack is saying the same thing. He's trying to explain why there's a difference, and he's saying, oh, there's a difference because the reason for the difference, one of the major reasons for the difference, is because we have declining admission rates, and that decline in admission rates is faster for Medicare than it is for all payers. Is that an accurate assessment of what you said, Jack?
Yes, I think so, yes. I mean, I think the key point is there are two factors that are coming into play. One is the mix of services and the fact that Medicare uses more inpatient services, which in general have a lower inflation rate. And secondly, that the rate of inflation that Medicare has experienced in inpatient services is depressed relative to everybody else because of the fact that Medicare discharges have dropped so rapidly.
And that seems totally reasonable to me. I'm just pointing out that I don't understand. I don't think that the two. I think the second factor is an explanation for the first, but I don't think you can add them together because they're not independent.
Well, I understand what you're saying, but I think you can.
Maybe we can look at that a little bit more offline. So, I'd like to look at that offline with you, Jack, and see how we mathematically can add them together. Because I do understand that the outpatient, and I know that you and I have calculated that the outpatient growth factor contributed, some considerable amount to the overall increase being higher than Medicare. So let's take that offline, and maybe we, if you and Stu and I can, and the staff can reconcile that, that would be great.
Okay.
Jack?
I should add. I think it is a good question, and I think it is a good question, and I did think about it when I was doing this, and I'm sure if we had a little time and pencil and paper, we could work out the conundrum here. So let me.
Are there other questions before we move forward? We have one or two other questions, Jack. Then we'll hop right at it.
Sure.
Jack, this is Michelle Mann. I'm curious, looking backwards is one perspective, and if we were looking to take this perspective and move it forward, what did you think about, and how would you course correct for the policy changes in the systems that were taking place? So between the move to TPR hospitals and the move to ARR hospitals, we would see that focus on chronic disease primarily in that older population, which would, because the state's been successful in reducing readmission rates and that sort of thing, are we taking that into account? I guess my sense is, and I could be very wrong about this, but my sense is that we're going through these policy changes and our volumes are going to do sort of a J-curve concept. And so you're dropping while you're putting programs in place that are aimed specifically at readmissions, which is specifically in, like, let's take the top 6 disease categories, which is particularly high in the Medicare population. So some of this drop is policy-driven, I would suggest, and that if we continue to think we're going to see a decline, my sense is that the work done on impacting readmissions and that sort of thing will continue, but there will be a point that it levels and the population starts to. So that's my J-curve concept, that the work gets to a certain point of homeostasis, let's say, and then population and the demographic move is going to start to pull that volume back up. So I'm just curious how you introduce these TPR, ARR policies into your thinking about projecting the history of these past 2 years forward.
First of all, hello, Michelle. It's nice to hear from you. I haven't really tried to do that. I have observed that the TPR hospitals have, in some instances, been very, very successful in reducing the level of Medicare services by focusing on the kinds of patients that you've mentioned. And I didn't hear everything you said, but I think I agree with everything that I understood you to say. That is, in particular, in the short term, as the hospitals go on global budgets, it's perfectly reasonable for them to focus on reductions in expenditures for the chronically ill, and those reductions in expenditures will be differentially Medicare expenditures, and therefore that experience will strengthen the likelihood that the difference statistic will remain high because of the fact that Medicare charges per fee-for-service beneficiary will be dropping or will be more constrained than the charges for the all-payer group. On the other hand, the other point that you're making is that eventually one could run out of opportunities, and I think that's also possible. So I hope I've responded to your question. I think.
Well, I was going to say, just to restate it, I guess the question that I have is, by looking at the 2012, 2013, and it isn't just going forward on GBR. In some ways, the hospitals have already been on a fixed payment or a reduction incentives, either through TPR or through the ARR program. So these numbers and these reductions that you're talking about have already and have in their differential this of change, because you're looking at this change, a lot of effort that's gone into care management of those chronic diseases that are in the Medicare population. And so it seems to me we can't use that same level of reduction going forward.
Our view, the staff's view, is that we've barely scratched the surface on care management with the Medicare population. The Medicare Advantage enrollment in Maryland is 10% versus 40% in a lot of major urban areas. The population is very unmanaged. Even with all the effort that we've put in, we still are showing very high readmission rates compared to the national averages. And when we did the calculation of potentially avoidable utilization, which we've been sharing, you would find that it is very much differentially concentrated in the Medicare population, and high medical. We have a high medical admission rate in Maryland. It's still above the national admission rate for medical admissions. The medical admission rate is particularly high in Medicare in Maryland. So the staff believes that there is still quite a bit of room to improve on that Medicare utilization, and some of it is through readmission programs, but also some of it is through chronic care focused delivery improvement programs.
So,
hello, Jack. This is Ray Gray. You and I have done some work in the past in looking at Medicare utilization by age brackets, right?
Yeah.
And so you did not take, there's an 18 or 19%, I think I ran the numbers while you were talking, in the Medicare population over the period of time that you're looking at, and there's a relatively smaller increase in the total population. So Medicare, you've proven, is growing at an ever faster rate. Should you take into account the age buckets, because we have proven that the older populations have higher use rates in the past than the younger Medicare populations, and should that be a factor that's applied? Given, Donna, you know, I hear you loud and clear, and we've got 6.79% reductions in readmissions forecast in the coming years, and I think you're right, there's an opportunity, but I still think that Michelle's point is a good one. At some point, we're going to hit a point where you can't continue to improve at an ever-increasing rate, and we're not going to shift rates to outpatient at the rate we did in the past. So My point, though, is should we look at use rates among age brackets among Medicare and have that apply in this concept in some way?
Well, I certainly think, Ray, it makes sense to use them for analytical purposes at the hospital level. In making this presentation, I was trying to just call out what I saw as the major reasons for the experience that we've had, and I think it probably could have been improved if I did it on an age-adjusted basis. So I guess that's it.
I think, you know, it would probably show that in spite of aging, that the differential statistic was still, you know, was still retained, that the Medicare was not growing as fast as the non-Medicare. But there is a point that you will reach where you've taken out a lot of that excess utilization in Medicare. I think our point is that the staff doesn't believe that we're close to reaching it in the next couple of years based on the data that we're looking at.
So, Donna, a question. For those on the phone, it's Hank Franey from University. I'm trying to follow this, and I think I do. And so, but based upon what you just said, that there is more opportunity in the near term, doesn't it make all this concern in this paper irrelevant, because that differential statistic is likely to continue given all the opportunities that we have here?
If we bear down on it and stay focused on it, then I think Jack's conclusion, and we'll have to let him get to it here pretty soon, is I think that's your conclusion, isn't it, Jack? If we keep focused on the goal of improving Medicare care, Medicare chronic care, and reducing avoidable utilization that is particularly notable in the Medicare population, that we can maintain a differential statistic.
Through utilization reduction, not price reduction.
Right. Yes, and the implication of that, the implication of maintaining the differential statistic, is essentially that the two waiver tests will become roughly equivalent. And as I've suggested, to fail the Medicare waiver test is, I think, to court disaster, because when the state attempts to apply for an extension of the waiver at year 3, if we're in the position where we've accommodated a substantial increase in the Medicare differential, the folks at CMS, I think, are going to take that into account in a very negative way. And that's going to raise the question of whether or not the demonstration will be continued. So I'm stressing the importance of focusing on this particular statistic, because it embodies the perspective which essentially says, if we're careful and we keep the statistic sustained by a variety of measures, most of which involve focusing on Medicare volume reductions, especially related to the chronic cases, then we can simultaneously meet the test, and we have a higher probability of getting an extension at the end of year 5. So let me. I do have just a little bit more work to get through here. If we go to slide 17. I just want to begin here by enumerating the statistics that will go into the annual allowance calculation. Remember, this paper is a proposal for how you calculate the annual allowance, and we haven't yet discussed the annual allowance. So I want to begin by just enumerating these statistics, and the first of which is the volume allowance, which has been, which would be viewed as a combination of the explicit allowances that are being given to the hospitals that are on the TPR and the GBR systems, and the amount of the volume governor that would apply to the hospitals that remain on the CPC systems. A key feature of this demonstration that will be necessary in order to make it workable is for these volume allowances to be very, very stringent. And the proposals that the staff has made with regard to these issues, including the negotiation of GBR hospital budgets and the volume governor for the CPC hospitals, are very much in line with sustaining a viable volume allowance because of the limitations that these volume allowances that the staff has developed represent. The second category I've defined generally as supplemental services. I've illuminated the main examples of those. They're primarily CON. And if we go on page 18, we have productivity improvements. Several of these have been represented in initiatives that the staff has developed. The fourth factor is the projected increase in Medicare hospital claims per fee-for-service beneficiary, because that is the standard relative to which we measure the second waiver test. And then the final two statistics are the projected difference statistic, and finally the projected increase in Maryland's population. So now I want to illustrate this calculation of the volume allowance using these statistics, and in order to do that, I've got to make some estimates. The first estimate I'm going to make is one that derives from the current hospital claims per fee-for-service beneficiary projections of the CMS actuaries, and these may need to be updated. But the last projections I saw were 1.9% for 2014, 1.6% for 2015. And in the second year, 2015, the Medicare savings target requires that the state beat the 2015 increase by 1%. Now, it would be very, very unwise to try to have that 1% savings realized solely in 2015 and have no savings in 2014. So in this little equation at the bottom, I've combined the 2014 and 2015 increases and offset them by the 1% savings target requirement and averaged them over 2 years. So in the example that I'm developing, I'm using an assumed rate of increase in fee-for-service hospital claims for fee-for-service beneficiary of 1.25%. This is not especially conservative, but as I said, I'm just trying to illustrate the approach, not propose specific statistics. Okay, then the second estimate that we need to make is the average supplemental service adjustment. In this example, I've used 1%. This is completely unrelated to facts or any information about how much the CONs will cost this year. It's just an illustrative number. I've assumed 0.5% for productivity improvements. And then on the next page, we have the volume allowances, which are a combination of the unmodified demographic adjustments in the GBR, which are 0.7. Those, by the way, are reduced a little bit because of staff policies relative to changing the weights, and the 1% of the CPC governor. So I've just assumed a mix of 2/3, 1/3 there, and the volume allowance assumption is therefore 0.8%. I've assumed a projected difference statistic of 2% based on the information that we've reviewed thus far, and I've assumed furthermore projected increase in the population of Maryland 7%. Now, given those 6 statistics, the volume allowance can be derived as we do on page 22. We start with the limit of the Medicare savings target, which I described earlier as 1.25%. That's the amount of claims for fee-for-service Medicare beneficiary. That's the amount of the claims increase for Medicare fee-for-service beneficiary that this annual allowance will produce. The difference statistic being 2% converts that claims increase into a claims increase per Maryland resident. So this system would allow the increase in claims per Maryland resident of 3.275%, which obviously is within the all-payer ceiling. With a projected increase in population of 7%, this means that the maximum increase in hospital charges would be 4%. Now, how would that 4% be broken down between the components that we've identified and the annual allowance? Well, the volume allowance we've assumed to be 0.8%. And I want to underscore that this derived annual allowance, which is fairly high, is only high because of this volume allowance restriction. The average supplemental service adjustment of 1% is combined with that. So 1.8% of the 4% are accounted for by those two charge components, the volume allowance and the supplemental service adjustment. 0.5% is built back in to the adjustment because I'm assuming that the productivity requirements will offset charges. And so the net effect of those three components, the volume allowance, the average supplemental allowance, and productivity, is 1.3%. That means that the maximum annual allowance that could be given in this proposed approach would be the difference between the total revenue, 4%, and the amount that is taken up by these other charge components, or in this instance, 2.7%. I just want to mention quickly what would happen using this proposal if one were to take a very conservative initial year assumption with regard to what you wanted for the Medicare savings target. That is to say, let's suppose we adopted the policy of go for O. In that case, the first line, the limit of Medicare savings, would be 0 rather than 1.25%. And the consequence of going through the calculations would be that the maximum annual allowance would also be reduced by 1.25% from 2.7 to 1.45. Now notice that the essence of this calculation is to ensure that the Medicare savings target is met. And what it depends on primarily is the maintenance of the difference statistic and the accuracy of the estimates the staff makes relative to volume and supplemental services and the productivity offset. I just want to conclude by mentioning making a few comments that suggest that a conservative approach would be called for. And this is the last page. So I read here, the derived annual allowances may not meet the Medicare savings target because, 1, the CM actuaries may overproject the increase in Medicare hospital claims. So therefore, we need to maximum extent possible to maintain updates of those results and to take a fairly conservative view of the projections themselves. Second, there's a delayed application of the case mix and volume governor, and that could result in volume increases that are unanticipated in the sense that they exceed the 1% governor that will eventually be put in place. A third very serious potential problem is an open-ended market share adjustment because there will be significant problems in making sure that such an open-ended market share adjustment is budget neutral, and also an open-ended market share adjustment provides hospitals with the wrong incentives relative to what the demonstration is attempting to do. And finally, the initiatives directed at limiting Medicare charge increases and maintaining the level of difference may prove inadequate. And this gets to one of the points that Michelle was making, that is to say we may run out of ability to differentially control Medicare expenses. The thrust here is that this is an approach. It's geared to meet both tests. It focuses on this particular statistic because I believe that the calculation, evaluation, projection, and maintenance of that statistic is what will ensure the success of the demonstration. I'm happy to take any questions.
Yeah, I have a question. I'm not sure I get everything here, but it sounds like what you're saying, and this is Jim McGee, by the way, it sounds like what you're saying is that if we can maintain the trends in terms of service utilization that are present in Medicare, that we're basically in good shape. And that would maintain this difference indicator. My question is, if we were to have the same kind of service utilization on the non-Medicare population, one, would that reduce the difference indicator? And two, would it matter in terms of our overall goals, or would we actually be in better shape?
First, if the reduction in utilization that the system experienced were uniform across the payers, it would reduce the difference statistic. And that in turn would mean that the amount of the annual allowance would be reduced somewhat. How an across-the-board utilization reduction in utilization would be handled in the rate-making process is, of course, a policy to be decided by the staff and the commission. So I think your initial observation that that you need to sustain the differential reduction in Medicare utilization is correct, and that we're in the somewhat ironic position that if we had a reduction that was uniform across the board, especially in the GPR and the TPR hospitals, the difference statistic would be reduced, and that would have consequences in this calculation of the annual allowance.
But would it have?
I'm sorry to hear.
But would it have consequences in terms of achieving the overall objective of the project, long term?
Yes, I think it would. Yes. In other words, the project I think is calling for a differential reduction in Medicare charges per fee-for-service beneficiary, and as Donna has suggested, it's a fertile field. There are a lot of things that can be done, even given Michelle's point that eventually you're going to run out of opportunities. But the fact that we have to meet this Medicare limit, the national increase in hospital claims for Medicare fee-for-service beneficiary, and save $330 million, can only be achieved if we focus disproportionately on the Medicare utilization of services. In other words, the fact that we have a dual test means that we have to, that we have to meet the dual test means that we have to accommodate the more stringent requirement that Medicare is placing on us. And one of the key things about this presentation is that it suggests that that is not out of the question. In fact, in the experience that we've had over the previous 5 years, it would seem entirely feasible that it could be done. But the thrust of this presentation is that it requires a lot of focus on Medicare, and it requires a rate-making system that accounts for our success in that focus as measured by this particular statistic, the difference statistic.
Jack, it's Dave Kraske. The differential statistic, that doesn't affect the Medicare savings test. The Medicare savings test is just whatever the Medicare increase was relative to the nation. So if we improve on the non-Medicare population, as long as we're still improving on the Medicare population, a reduction in the differential statistic I don't think impacts the savings calculation.
It will require the implication of a drop in the differential statistic is that it will require that the annual allowance be reduced, because the annual allowance will need to be reduced in order to have the two groups, the all-payer and Medicare groups, simultaneously meet the Medicare savings sharing requirement, i.e. the national average, for the reason that there won't be any difference in the growth rates.
That's assuming that we allow for the 3.58% increase per capita. So, okay.
And yeah, I mean, we're going to if we can't sustain the different statistic, if we can't focus on Medicare, the 3.58 amount cannot be realized, and with the condition that the Medicare savings targets are met.
Yeah, I agree with that. Okay.
Yeah, Jack, this is John, and just to answer that, the beauty of this is by maintaining the different statistic, then we can just focus on the all-payer rate of increase and be able to sustain, as long as we sustain that difference, then we're going to be able to achieve the Medicare at the same time.
But the differential statistic only has to be that 0.41. It doesn't have to be 2. The 0.41 creates $330 million in savings, if I understood the presentation. 0.44. Or 0.44, whatever that number is. So that differential statistic only has to be 0.44.
No, the differential.
Well, the difference statistic, when considered in the light of the annual allowance and the other factors, has to produce a rate of growth in Medicare claims per fee-for-service beneficiary that's 0.44 below the national average.
But in order to do that, you got to.
Sorry?
No, go ahead, Jack.
I'm sorry.
Go ahead, Jack.
This is John, and what I was just saying in response to that is that in order to achieve the 0.44, by having the differential statistic, we can concentrate and focus on the all-payer level of 3.58, and we don't have to make any additional reductions or changes to the overall rate of increase to the hospitals. Therefore, we get to achieve that 0.44 by providing the higher rate of increase target around the all-payer, 3.58.
Mm-hmm.
No, not the savings test, but it would reduce the amount of rate increase that the staff can provide hospitals, because if the differential would shrink.
It seems to me, by having looked at it too, Jack, that it depends on what the estimate is for the Medicare increase. So, you know, as the Medicare increase gets larger, then the differential doesn't have to be as high. So if Medicare increase is smaller, then the differential has to be greater to maintain the savings at the 0.44. So it's not a completely fixed item. It's really relative to what's happening in the Medicare rate of increase.
Yes.
Right now,
that's exactly right.
Right now, Michelle, the Medicare projections are showing that S-curve, and in year 4 and 5, they're showing a higher increase than they're showing in years 1, 2, and 3. However, their policies for savings don't usually get factored in until time comes closer. So we can't count on that S-curve, and quite honestly, if we actually had that curve, it creates a very considerable pressure on the 358 as an overall limit. If Medicare were actually increasing at more than 3% per capita, we'll all be holding on to our seats, because that'll really put a huge pressure on the 358.
Right, but to follow up and using Jack's model here, if the number went in the opposite direction and the Medicare savings in 14 and 15 were in fact not 1.9 and 1.6%, but in fact 0% in both of those years, he's suggesting that limit and that it comes down by the 1.25%. The maximum annual allowance comes down by 1.25%. The maximum increase in hospital charges comes well down below 3.58%. And then potentially you have a woefully underfunded system to do all of the system change that we need. So to me, I guess the bottom line question I have for you, Jack, if this is dependent on the actuaries' projections of defining what the annual allowance should be, depending on a projection of what the Medicare savings or the Medicare expenditures will be nationally. How is that different than how we've handled this model discussion in terms of rates over the last couple of years, where if the Medicare cushion was 10%, we might have done one level of increase, but if the Medicare cushion was projected at 0%, we did a very low, if not negative, update to hospital rates. Isn't that essentially the same way we've behaved in the past few years with regard to trying to project at what the Medicare savings or the Medicare expenditure rate would be?
Yes, I think that's a good part of the picture. The other part is that if Medicare takes a very tough line, or if Medicare has extraordinarily favorable performance relative to its growth in Part A and Part B expenditures per fee-for-service beneficiary, then what that's saying to Maryland is, if you want to have hospital charge increases that begin to approach the all-payer ceiling, you need to apply initiatives that are highly focused on the reduction of Medicare expenditures. And if you do that, and if you're successful, then the aggregate expenditures, the aggregate charge increases that are available to the hospitals can approach the all-payer ceiling. But for that consideration, which is, what will the different statistic turn out to be? The rest of what you said, I think, is entirely right. In other words, you're going to ratchet the system up and down based on Medicare experience. But here you have an additional variable, which is, Donna, I think, has quite rightly pointed out, is a very powerful opportunity to have the industry benefit from highly focused initiatives on Medicare.
And I'm not arguing that at all. I think that's clearly the focus. I was just suggesting that in terms of us discussing a balanced update, that in the past we lowered the unit rate increases because we debated over where the Medicare waiver cushion would be. And the higher you expected that cushion to be, the higher you could allow that update to be. And you're essentially describing a model here that does that. The only difference is we're bringing outpatient into the conversation, where before we just looked at inpatient charges, that if we think the national spending trend for hospital spending nationally fee-for-service beneficiary is below what you have here in this model, you have to push the update down for all payers in order to achieve that Medicare savings.
But I think what Jack is saying on your next to last slide, Jack, this is Ray Gray.
Yeah, right.
If I'm looking at that correctly, the top half of that slide indicates that the available update, the available amount in rates in total, is around 4%, and that they're assuming we keep the pressure, if you will, on reductions in Medicare utilization. The differential is about 2% between the full amount of revenue that could be generated and that which would apply to Medicare. What you've done on the bottom part of the page is you said, okay, here are the components of that 4%. This is the amount that's volume, productivity, offset, et cetera. So I read that page as two pieces. The top half is sort of the total revenue available. The bottom half is what are the components. Did I read it wrong?
No, brilliant. Very well summarized.
The part that, it's Jim McGee again, the part that I'm having a hard time getting my arms around, there seems to be this notion that if we can reduce or squeeze more savings out of the system, that we come in less than the 3.58%. And as somebody who writes the checks and signs the checks that support the system, I'm having a hard time understanding why this is a bad thing.
I'm sorry, you're asking why it would be a bad thing if we came in below the 3.58?
Correct.
Yeah. I'm not suggesting that it's a bad thing. All I'm suggesting is that if the system is to work successfully, by which I mean it meets both waiver tests, then it's very much in the interest of the industry to maintain this different statistic at as high a level as possible, which means that it must adopt initiatives that focus on Medicare utilization. And if it does that, it's under those circumstances that it gets the benefit of the 358 ceiling. I'm not saying that that's top public priority. I'm talking more to the hospitals than I am to the public policy.
So I think the balancing act that the advisory council pointed out was the need to make infrastructure investments so that we weren't just focusing on utilization reductions, but we were actually focusing on care improvement and quality improvement and sustainable changes in the system. And my personal view is that we've signed up for a 770,000 member Medicare Advantage program, and we better very quickly make some of the infrastructure investments, and it takes funding to make infrastructure investments to improve the quality of care delivery and not do it and to do a good job of it for the Medicare our Medicare residents. And so, we want to encourage a quality approach to care delivery improvement. And I guess where it might be good to be lower than 358, one would have to, if we get to a discussion, for example, if Medicare decides to fund SGR dispensation by cutting hospital rates, and so what if the number went into the -2? Let's just make up a scenario. So what is the fair and reasonable application of policy that the HSCRC, that the Commission needs to make relative to that rate of change in Medicare? What policy decisions does HSCRC need to take into consideration? And so low might be good, but too low might not be sustainable. And so that's the advice that we've been given today. And I know that we could go on for quite a bit more discussion. We actually made some good progress on rewording some of the principles that we might apply to the ongoing discussion of how to make this adjustment. But I think we're going to get kicked out of here so that they can get set up for the next meeting. And we won't have a good bit of time today to go through that, so we're going to have to defer that to the next meeting. And I think we're already at the over the edge of the witching hour, and I'm wondering. I think we're going to have quite a bit of territory to cover at the next meeting to prepare for some recommendations to take forward. So I think we'll have to potentially look. I think our next meeting is. It's only a 2-hour meeting, so I don't know if that's going to end up being enough time to get through everything that we need to get through to get a recommendation or a thought process out of the box. So we'll take a look at that. Are there other issues or questions or comments or considerations that we need to put into play for the next agenda? I think we have a...
Hey, Donna, this is Gary. Gary Simmons. The question I have, there's a ton here of discussions we need to have. Are you comfortable that, with obviously the work that's got to happen, recommendations, whatever, for the July 1, update, whatever that means, are you comfortable that we've got enough time right now blocked out on the schedule to get to make that happen?
Well, I think we have to go back and take a look at that. We may need another meeting on the books. I think part of it is we have several small groups of folks who are working outside of the meetings on particular issues of being able to bring that back in an effective way, and also for us to effectively take what's been presented and move it forward through the process. In some respects, the information that Jack has presented isn't really in diametric opposition to anything that was presented by MHA in general, but I do think that some of the principles need to be taken through discussion. And we have a lot of nuts and bolts that we need to tackle before May, for example, on UCC, on the contracts, on some of the other things that we have assigned to the smaller work groups.
Donna, could you give us an update on the smaller work groups? Have they started, or?
Just one of them has started, and that was to take the principles from the last meeting and to reorganize them for us to review and discuss. The other two work groups have not met.
We are adding, for the scaling one, we are adding members from the performance work group, so since it's an overlap between those two. And for demographic adjustment, we may have additional members outside of the work group as well to help.
I just hadn't heard anything back,
right.
So I was curious.
I think by the end of today or tomorrow, you'll have some scheduling emails coming to you.
So we actually have 3 little work groups, if you will, in addition to the principals work group, and we talked about needing to add one today with UCC, the uncompensated care. Are there people here who are particular to being interested in working on that? So we have Kristen and Ray and Hank and Stu, and James and Mike, and we may look for others outside of the work group. I see a few more in the audience here, but so we'll put together a group of folks to look at the UCC issue outside of the meeting. I don't see how 2 hours will be enough for us to cover what we need to cover in our next meeting, but we'll put our heads together and get back to you on that front. Are there any comments from the audience? I forgot to ask for comments, and even though we're over our time limit, I want to make sure that I provide that opportunity for comments from the audience. Any other questions or suggestions? Well, I will adjourn and clear. Thank you.